All right, well, good afternoon. I'm Michael Gropper. For those of you that don't know me, I'm the chair of the Department of Anesthesia, been so about 9 years. And there are a lot of things that you have to do as a department chair. I'm going to spend about the next 20 minutes telling you all the difficult things. But there is nothing that's more satisfying or fun than something like this, for sure. We're here today to celebrate George Gregory, and we're going to talk about him a little bit, maybe embarrass him a little bit as well. But it's so great to see a lot of familiar faces, many that I haven't seen for many years. Before we start, I just want a few thanks for the people that have set up this event. Anshuman Sharma, who you're about to hear from, who is our Director of Pediatric Anesthesia Research, Matthew Bratko and Ed Matthews over there, Susan Fernandez, Morgan Ahern, who is online, who helps us with a lot of really is our archivist and historian that sees some of the pictures you're going to see, Danny Cambier, Mike Mullen. And I also want to really welcome those people who are on Zoom. I don't know how many we have. Ed, you'll tell me. 43. 43. So a great turnout, which I think is absolutely a testament to George and the impact that he had on all of us. So here's our program. I can just say a few words, and then we're going to hear from a few others that you can see there, and then we're going to hear, most importantly, from George. We know George from the NICU. I have some embarrassing pictures of him, particularly the one on the right. If it would fit me, I would ask him, could I borrow that tuxedo? But, many fashions come and go. I'm not sure that one's coming back, but you never know. But what you can see here is, George, most importantly at the bedside, and I think many of our memories are just that. No one who is more dedicated to patient care, who would do anything. And I remember saying for many years, if my kid is ever really sick, I want George to take care of my small children, maybe even my adults, because some of you remember he also then joined our inaugural adult liver transplant team as well, which sort of showed the depth and breadth of his skills. But George has been an icon in our department, remains so. He would come and work with the residents here at Mission Bay or at Parnassus, teaching them primarily in the operating room, not necessarily being the attending anesthesiologist. And I would enjoy probably a couple times a year where my cell phone would ring and it would be George. And he would say, how come these residents don't know pulmonary function testing? I wasn't even chair at the time. Somehow that was my fault, which I kind of liked because he felt like he must think that I must know that stuff. But why some particular resident he worked on that day didn't know it, I took full responsibility nevertheless. But it shows you the level of commitment that George had. I am going to take 1 minute, sort of on a personal level, to talk about somebody who also had a huge impact on me. You can see here John Clements. When I came here in 1981 to do my PhD in the Cardiovascular Research Institute, he was one of my thesis advisors. And there's a nice story in the UCSF News about him. He really, you needed both George and John to be able to do what was really done to save the lives of, I don't know if it's hundreds of thousands or millions of premature infants. John never practiced medicine. He went to medical school and is, I think to this day, still the most brilliant man I ever worked with at UCSF, and also had an incredible sense of humor. And when you didn't know something, and I often or frequently didn't know anything, he just made me feel like that was okay. And he would guide you to the answer of whatever it was you were looking for. A huge loss for us, but a full life at 101. I just wanted to celebrate John. For those that don't know, he just really discovered surfactant, and what was it? Why did premature infants die? And so John's understanding with Mary Ellen Avery at Harvard, that they didn't have surfactant when they were premature, and then it developed later. But at the same time, then at the side of George, as he developed CPAP, as you're going to see in a little bit. So that's a little bit of a personal thing for me. It was, celebrate a great life. But I think we've also lost Rod Phibbs a couple months ago. So a real change. So I'm so happy that we're having this today with George. And I'm now going to hand off to Anshuman Sharma, who is our Director of Pediatric Cardiac Anesthesia.
Thank you, Michael. and thank you, everyone, for joining us. My statements and whatever I say are not going to be as personal as I can't show you pictures of George in those fancy outfits. But what I would say is it's a distinct honor and a pleasure to welcome you to this lectureship. The first of many, hopefully, aptly named as the George Gregory Pediatric Anesthesia Lectureship Series. I would tell you how your work has impacted somebody like me sitting 8,000 miles away in India. But what I can say for sure that what I see you as a true perioperative physician for all ages. You saved several thousands, millions lives in the operating room, in the neonatal intensive care unit, in the pediatric intensive care unit, in adult anesthesia intensive care units, while doing remarkable work with your research. For those who don't know, what we heard that the use of CPAP in the premature neonatal babies, that paper is still regarded as the 3 most impactful papers in the last 50 years by the Great Britain Society of Neonatologists. So your work across the subspecialties is remarkable, and it's not surprising that you hold a unique distinction that you have been honored by multiple societies, not only just the Society of Pediatric Anesthesiology, but also American Academy of Pediatrics twice, and many neonatal societies across the country. And if these achievements were not enough, Dr. Gregory continues to teach till the day. He continues to mentor students, instilling his knowledge, wisdom, and passion into the next generation of physicians and pediatric anesthesiologists. Having read a poorly photocopied, bootlegged copy of your book, 8,000 miles, I do owe you some royalty, but I can personally attest to the fact that the impact you made was tremendous. And you know, your work reminds us every day that what we do is a privilege. And if I can achieve a fraction of what you did at the end of my career, I would call it a resounding success. So many of your trainees are in the audience, and they have developed very successful career of their own. I'm going to invite 2 of them. We'll start with Marla, who's our vice chair, executive vice chair and of pediatric anesthesiologist, and we'll follow it with Dr. Jeff Feynman, who's the chief of pediatric intensive care units at UCSF. So Marla, please join us.
Thank you, Anshuman, and welcome to everyone who's here today. What a treat to see so many familiar faces and some faces I haven't seen in a long time, and I'm sure an equal treat for George. So during this part, I just want to take some time to acknowledge Dr. George Gregory's impact on our division, as well as recognize his enduring commitment to education. But first, I need to start with a story. From George, I learned that pediatric ORs are very different than adult ORs. When I was first a brand new resident here, I worked with George. We were assigned to take care of a teenager with idiopathic scoliosis for a posterior spinal fusion. And prior to induction, I dutifully connected the pulse ox, the blood pressure cuff, and then I started to attach the EKGs. George stopped me. "What are you doing?" he asked. And so I explained I was putting on the EKGs. And he said, "Well, why would you do that?" he asked. Now, remember, I was a brand new resident at the time. I hardly even knew where the EKGs went on the patient, let alone, why. So I said something like, well, to monitor the heart, at which point he kind of scoffed and said, the patient is going prone. If we put the EKG leads on, we will just have to reapply them once the patient is positioned. You don't need to put them on. So that is what we did. Then a few weeks later, I was assigned to another spine case, but this time it was an adult patient with an adult attending. I dutifully put on the pulse ox and the blood pressure cuff, but intentionally left off the EKGs. When my attending, who, if I remember correctly, was Dr. Casorla, who's actually here in the room with us today, came in for induction, she was aghast. How could I possibly think it was okay to induce without EKGs? I quickly apologized and told her that I'd been instructed to do so last week, at which point she was very curious to know who had taught me that. And so I gingerly said, Dr. Gregory, after which she proceeded to suggest that perhaps pediatric people approach inducing patients in a different way than adult patients. So it was an important first lesson. Soon thereafter, I also learned that drinking Diet Cherry Coke in the adult operating rooms was not acceptable in the same way that it was at the time in the pediatric ORs. But I knew where my career was headed, and that was straight to the pediatric land. In all seriousness, though, George was and still is dedicated to our trainees' education in ways that continue to boggle my mind. As anesthesia residents, many of us remember attending resident case conferences every Tuesday morning. Which George ran over the years with many of our departmental leaders. During these conferences, a resident would present a particularly challenging or difficult case, and anesthetic management strategies would be reviewed. George always distilled each case down to the respiratory and cardiovascular physiology principles that really underpin our specialty. And in doing so, he awed his audience with his ability to both understand and explain the how and the why better than anyone I have ever met. He also took residents on field trips to the nursery or the neonatal ICU to demonstrate these principles in real time. After George's retirement from UCSF, he still continued to come in each Tuesday morning to sit with a resident in the pediatric operating room and teach physiology. Even when we moved to Mission Bay in 2014, he would make the trek down from Marin a couple of times a month to teach. When the pandemic hit and in-person sessions stopped, Zoom became his answer. Today, 20 plus years after retirement, he still Zooms into most of our resident case conferences and fellows lectures each week. What a privilege and opportunity for our residents and fellows. Without a doubt, George's grit and commitment to the education of trainees has inspired countless residents to enter the field of pediatric anesthesia. He has also left an indelible mark on our division by helping to populate it with faculty that he mentored and taught as residents. George supported me through my application to Pediatric Anesthesia Fellowship and wrote one of my letters of recommendation. When I arrived at Boston Children's, Bob Holzman, another pediatric anesthesia pioneer, greeted me on the first day with, "Oh, George told me to look out for you. Welcome." What a treat to have George's legacy pave the way for me as I embarked upon my career. After completing fellowship, I was lucky enough to return to the department and join the faculty. Then I was privileged to have George, the master educator, be my colleague. And despite the fact that he basically invented the field of pediatric anesthesia, George always valued his colleagues' opinions. I asked around for a few stories about George, and this one, shared with me by Atsuko, highlights this. Atsuko told me, "When I first came to UCSF, I was in awe of all the anesthesia legends, especially George. I was hired to do adult anesthesia with the promise that eventually I would be able to join the pediatric anesthesia group. No matter my assignment for the day, I was always drawn to the pediatric ORs every chance I got, mostly to be near George Gregory, because he wrote the Bible for all the pediatric anesthesiologists in the US and probably around the world. I remember one of the first times he spoke to me. He asked me if I used IV caffeine to help wake preemies up after anesthesia. I wasn't sure if he was pimping me since I was less than 2 years out of training, or if he was actually asking my opinion. I was flattered and terrified at the same time. It turns out he really wanted to know my thoughts. Like all great educators, George was a lifelong learner. Somehow, George is able to maintain rich curiosity and humility while still being a foremost leader in our specialty. George's passion for learning and his relentless pursuit to advance the field of pediatric anesthesia, not just at UCSF, but really all over the world, is truly remarkable. In honor of his dedication to teaching, in 2020, our division started a fellow teaching award named the George Gregory Teaching Award for the graduating fellows to give to one pediatric anesthesia faculty member each year. Though undoubtedly, none of the faculty even come close to being the type of teacher that George has been, his passion for teaching is forever memorialized through this award. Similarly, this new annual lecture will also continue to carry his legacy forward to allow us to learn from other thought leaders who advance the specialty of pediatric anesthesia. It's such a pleasure to recognize his impact in this way. So thank you, George. Your wisdom, tenacity, strength, and dedication have made our division, our department, and really the world better. Thank you.
I'm Jeff Feynman. I'm not an anesthesiologist. I'm sorry, but it's even more of a privilege for me to be asked to speak and say a few words about Dr. Gregory, not being an anesthesiologist. So thank you for this opportunity. I first met Dr. Gregory when I started my pediatric critical care fellowship in the late 80s here at UCSF. And in those days, you spent a few months kind of functioning as anesthesia resident before they allowed you to go into the ICU, which was great training for me. Appropriately, they never let us go to a pediatric OR, so I didn't get to work directly with Dr. Gregory during those months as an anesthesia resident. But I did know about the book, I did know about Dr. Gregory, et cetera, from being around the ORs. And when I first met Dr. Gregory in the ICU, I was starstruck. I was, filled with respect and admiration, and appropriately completely intimidated and very, very scared. Being this close to Dr. Gregory 35 years later, I feel exactly the same way. Anyway, we were privileged to be able to work with Dr. Gregory in the pediatric ICU. Unfortunately for our patients and for the field, his work in the ICU as an attending stopped from my standpoint and from the field standpoint way too early, but I was privileged to have the opportunity to work with him. And I still remember those days before rounds, he'd push us into this corner little workroom and give us these physio lectures, which were predominantly deep physiology lectures. And he'd start by asking us a question. And I still remember those questions. And I asked our fellows to this day the same questions because I didn't know the answers then. And now I do know the answers. But it was just an incredible, incredible educational experience that I've never saw before and have never seen 35 years later. And honestly, still at the bedside in the ICU, I know he's, changed the whole field of pediatric anesthesia, but he's had a tremendous, tremendous impact on other fields, not just neonatology, but pediatric critical care medicine as well. And I think that's one of the reasons why I wanted to speak today, because at the bedside, I still utilize the tools and the concepts that he taught us in a very short period of time. Nothing's changed. I mean, it's just, and we hopefully pass it on, not to the same manner that Dr. Gregory did. No one could do that, but it's still so important for the care of our patients. And even dropping kids off in the ICU, I remember he would say, yeah, the patient desaturated. And now almost everyone, that's where the discussion starts and ends. But it didn't end there. He would tell you why he thought the patient desaturated from a physiologic standpoint. And he would explain to you what you should, within that physiology, what you should do to prevent it as you take care of the patient during their ICU course. You just don't have that anymore. It's just really, I really appreciated that educational experience. I think one of the reasons they asked me to speak is because I dabble a little bit in physiology research, nothing to the extent of many of the people here, but I do want to just acknowledge some of the things beyond CPAP, obviously, which you're going to hear about from Dr. Gregory himself. But he's had tremendous advances in many other fields as well from a research perspective. If you go to the neonatal ICU these days, hypothermia is commonplace following birth asphyxia. Well, if you go back in the literature in the early 1990s, I think it was 1992, Dr. Gregory published a paper showing the beneficial effects of hypothermia following global asphyxia in, I believe it was rabbits. And first one to do that. He was one of the first, if not the first, to talk about anesthesia, the need, and how to anesthetize premature babies. As a pulmonary hypertension physician, I still go back to the landmark papers that he talked about persistent pulmonary hypertension in the newborn, explaining the physiology, and one of the first papers to actually describe the physiologic effects and hemodynamic effects of pulmonary vasodilators in that setting. So his impact goes way beyond the field of pediatric anesthesia, pediatric neonatology, pediatric critical care, and obviously adult critical care as well, both from an educational standpoint, a research standpoint. So although I'm completely intimidated and still scared of you, I thank you so much for everything you've given to our field, to our patients, and it's a deep honor to be here. Thank you.
Please join in welcoming Dr. Gregory, and we request you to come on the stage and give your first inaugural lecture.
Thank you all. I'm overwhelmed. I probably ought to stop here. First thing to do is take this mask off. I appreciate everything that was said. But before I go very far, I want to say what I really strongly believe. And that is a intensive care, adult ICU, pediatric ICU, neonatal intensive care is a very expensive place to die unless you have really well-trained nurses who spend their time there 24 hours a day, look at the patients and inform you when there's a problem that you can solve together. So I think before we do anything else, we have to appreciate that they are the ones who make these things work. So I also thank Michael and everybody else for this incredible honor. Never expected in my whole life that I would have something like this happen, but thank you. I really appreciate it. Anshuman, thank you. So I'm gonna, can you change the slides? Okay. Okay. Turn this a little bit. I've had 13 spine surgeries. I still have back pain, so be careful when you have the first one. But I did tell Phil Weinstein that we could stop because I'd put his daughter through Yale. And he said, no, you can't, because now I have grandchildren. So I was asked to describe my journey in anesthesia, how I was able to provide patient care, research and teaching, hopefully at a reasonably high level. And it's clear to me that the people are the key. It's the people with whom you interact day in and day out that make it possible for you to do this. And because they're the ones that question what you do. They don't believe you half of the time. And that's a good thing, because it's very easy to believe that you're right when you have some idea that's in your mind. And other people's job is to tell you when you're wrong. And so I greatly appreciate them. And then I've told you about the nurses and the people in the laboratory and the neonatal intensive care unit. They were incredible. 24 hours a day, I could get blood gases in less than 5 minutes. I could know how they were doing and how this patient was doing. So they were really important. And Maureen Schluter was the one who was in charge of that and did well. And Teresa Poirier was the head nurse at the time when we were doing all of this. And Teresa was one of those people that I greatly admire. She could get you to do whatever she wanted you to do and make you think it was your own idea. And she did it over and over and over again, to Joe Kitterman, who's sitting back there, to Bill Tooley, to me, to Rod Phibbs. And we all thought it was our idea. It wasn't, it was Teresa's. Next slide, please. So my journey in medicine started when I was 8 years old. I had an abscess in my right lower leg. It was large, painful, red, swollen. And I went to this doctor and he sprayed some ethyl chloride on there, lanced it, drained an enormous amount of pus out of it, washed it out with sterile saline, packed it. And here I am 82 years later with the same leg that functions pretty well. And I thought, God, that's really pretty neat. Maybe I ought to do that. And that's when I started thinking I was going to be a doctor. And I really never changed after that. And fortunately, I seem to be curious. Joe Kitterman thinks I'm curious in a different way, but I was curious about everything. Why do things work? How do they work? And why don't they work? Those are questions that should be in our minds all the time when we're trying to think about what we're doing. When I was in the Army, for some reason, they made me a corpsman and they made me a surgical technician. And I met Dick Gardner, who was a surgeon at UCSF. He was the chief of surgery. And so I got to know him. I worked with him a lot. And when I came up for my interview for medical school, I just dropped by to say hello to him. I wasn't asking him for anything. I was just asking him, wanting to say hello to him. The next day in my chemistry class at UCLA, I was told I had a call and I had to go take it. I went and took it, and I was told that I would have been accepted to medical school. Now, I think Dick Gardner had a lot to do with that. He never admitted to it, but I'm pretty damn sure that that's what happened. You can't do that nowadays, but he did it. You could do it in those days. When I was in medical school, I was given the great privilege of working with Bill Garut. And Bill Garut was a neurologist who was an anatomist also. And I spent 3 years of doing research with Bill while I was a medical student and got a couple of papers out of that, which was helpful in getting me my residency, I think. And then I was a surgery resident at UCSF. I thought that's what I wanted to do, but they made the mistake of putting me on anesthesia for 3 months. And I found that much more interesting because there was a lot of physiology, pharmacology, things that I wasn't getting as a surgery resident. And so I went to see Dr. Cullen and I talked to him. I told him that I would like to switch to anesthesia. And he said, okay. He didn't have a committee. I mean, he didn't go to a committee. He didn't say it to anybody. He just said, okay. And I became an anesthesia resident 2 months, 3 months later. And that's one of the major things that's changed in my life. Next slide, please. And this is Rod Phibbs. Rod was my friend until he died a few months ago. And Rod was a pediatrician. He was a chief resident in pediatrics at the time that I was in medical school. He lived at one end of the student housing, up in the student housing, and we lived at the other end of the building. And so we became really good friends. We went fishing when we could. But what Rod really did for me was he took me to the nursery many nights just to see the patients. And he spent a lot of time teaching me about pediatrics because I went to the nursery with him. And I became quite interested in that. And the major problem in the nursery was hyaline membrane disease, and it still is in many parts of the world. And it gave me exposure to the newly developed NICU. Well, when I was on OB anesthesia, I probably shouldn't say this, but I spent most of my time in the nursery because it was a hell of a lot more interesting to me. And so I did that. And they had very few survivors of mechanical ventilation. In fact, they'd had one. And so I tried to figure out how we could make that better and what was the problem. And one of the obstetricians told me a really interesting story about racehorses in England. He said, if these horses are born out in the field, they do really well. And they don't have any problems. If they're born in a barn, they frequently have hyaline membrane disease. Now, what's the difference? Well, the difference is that in the barn, they clamped the umbilical cord quickly, and they never got their transfusion from the placenta. And that was the real difference in the two. And it subsequently was shown in great part by Rod Phibbs that it makes a big difference in your blood volume and your hemoglobin if you clamp the cord early or clamp it late. And so that's become a significant part of neonatology at the present time. And as you heard, Mary Ellen Avery, at that time, in 1958, was an intern in pediatrics at Harvard. And she read that paper by John Clements describing surfactant. Now, why was a pediatric resident reading a paper in this kind of journal? I have no idea. But she was a very bright lady, besides being a really good human being. And she went to Jerry Mead, said, you know, I think the problem that kids have with their hyaline membrane disease is because they don't have surfactant. And Jerry Mead, being a really famous pulmonary physiologist, said, well, maybe we can figure it out. So they went to John Clements, and John made them a Wilhelmi balance. And a Wilhelmi balance is a device in which you can put a surfactant or anything on there, and it changes the surface tension. So she took the ground up lungs of babies who had died, put that on there, and saw that it didn't change the surface tension. So she clearly demonstrated that they didn't have surfactant. And that was probably the most important paper that's ever been written in neonatology, in my mind. And then about a couple of years later, John Clements, Bill Tooley, and Chu, and a bunch of other people went to Singapore to study hyaline membrane disease. Now, why would they go to Singapore? Because they had 36,000 births in this hospital a year. And many of those kids were really sick, premature babies. So in a short period of time, they could gather a lot of information. They defined a lot of the physiology of what was going on in those babies. And so if you read those papers, you come away understanding the physiology of this disease much better than you could before. And so I fortunately had the ability to read that paper because Bill Tooley gave me a copy of it, and I read it, and that was very helpful. Next slide, please. Well, these two people are people who really affected my life, Bill Hamilton and Bill Tooley. And Dr. Hamilton at the time was at the Iowa, in the University of Iowa, and was a chief of anesthesia at the time. And he came there and worked with Bill Tully in the neonatal or the cardiovascular research institute, and they were interested in studying the lung disease. And so they were lifelong friends. And Bill Tully knew of my interest in the NICU because he knew that I went there and spent a lot of time when I was an OB at that time. Well, he called Bill Hamilton, and Bill Hamilton said, can George come and work in the nursery? We need some help with mechanical ventilation because it isn't working very well, and we'd like to have him come and help us. We know he's ventilated adult lungs and some children too. And Dr. Hamilton said, sure, go ahead. And not only did he say that, but he paid my salary for the year. Now, there aren't many chairs around, including the one sitting in the front row here, who would pay your salary to go work in somebody else's department. It isn't done. But Dr. Hamilton was interested in pediatric anesthesia, and he was interested in the disease of hyaline membrane disease. So I came and when Dr. Hamilton came from Iowa to be the chair at UCSF, I went to the nursery for what was to be a year and turned out to be 45. But the first year that I was there, I spent most of my time in the nursery. And I think that made my wife happy because I wasn't hanging around the house. When I retired, she said, yeah, you can retire, but you have to do two things. You have to learn how to cook, which I did, and you can't hang around the house. So I went back and did some anesthesia at UCSF for a few years until she got used to my being around. But I spent most of my time there doing the most important thing that people can do, and that is that I was learning from the patients. I was watching them. How do they breathe? What do they do? What happened to their blood pressure when they breathe? And we had continuous blood pressure tracings at that time on a grass recorder, which was, nobody else had that. And that was because Tully came back. That's what they used in Singapore for their studies. And we got some and used them. And I learned an enormous amount from those patients and from looking at all those graphs. And the nurses were the ones who were responsible for the graphs and for this information. And then there wasn't much known about mechanical ventilation and in newborn infants or anywhere in the world. And that gave me the freedom to experiment with ventilation and see whether I could make it better. And there was a paper by Harrison, which I'll describe in more detail, and from South Africa that came out that literally changed my life. And I will talk about that. And there was no research committee at that time. It didn't happen until 3 or 4 years later. And so that night, I was able to apply what I thought was should be done to treat these patients. And that was continuous positive airway pressure. And I'll describe more about that in a few minutes. But we published the paper in the New England Journal. And as most of you know, for any new development to take hold, it takes 10, 20, maybe sometimes 30 years for that to happen. It happened immediately here. And it happened immediately because this was a serious problem that was the cause of death, the major cause of death in the nurseries all over the world. And so it was adopted. And it was one of the original forms of applied research, I think. And then Dr. Hamilton needed somebody to run the adult ICU for a couple of years because Dick Schlobaum, who wasn't around at that time. And I went and ran the adult ICU for 2 years, which was an interesting thing for me because I learned a lot there. And I learned a lot that I could apply in the newborn intensive care unit, just like what I learned in the newborn intensive care unit could allow me to do that. And then a few years later, I was asked to start the pediatric intensive care unit, which I did. And then after a couple of years, I went back to the nursery and then remained there for the rest of my career. Next slide, please. Well, this is Ron Miller. Some of you people know Ron, some of you don't. But Ron was one of my anesthesia classmates. And he went in the Navy afterwards in Vietnam and did some incredible in research there, and it actually defined trauma hematology. And much of what we now know about that, Ron defined while he was there doing that. And I had incredible respect for Ron, because once a patient came in with a hand grenade embedded in his abdomen, and the people said, no, you can't, don't you go and do that. Don't you do the anesthesia for that, because if it explodes, we lose you. And Ron said, no, I'm going to go do that because you have much more to do in the future than I do. And therefore I'm going to go do it. He went and did it. Fortunately, the thing didn't explode when they took it out, and he survived. But he allowed me to continue working in the nursery when other people thought I should go back to the operating room and only work in the operating room. Ron just let me go and continue doing that. And he also supported my development of pediatric anesthesia. When at that time, everybody in the department did pediatric anesthesia. But Ron let me develop a pediatric anesthesia service in the department. And that included a lot of people that are in this room. And we improved, I think, the care of pediatric patients. And we did some reasonably good research, I think, that helped advance the field. And he supported research at all levels. And it was he who started the types of research that's being done in the department now. He made it possible for it to be done. Next slide, please. Well, I had good people to do research with. Bill Garut was great. He was supported me. He taught me. He did a really good job. And then during residency, I had the privilege of working with Ted Eager. Ted was the person who developed MAC so that we could tell what the level of anesthesia was in patients. And when he published that paper, I went to him and I said, Ted, do you think the anesthesia is different in infants and children and adults? He said, I don't know. Why don't we find out? And so while I was a surgeon, an anesthesia resident, we did the MAC studies in children and compared them to adults. And we found that the children had different anesthetic requirements than the adults did. And so that helped advance that. And then I worked with Skip Way, and we studied singultus, which is hiccups in plain language. And if you're a surgeon, you get really upset when patients start developing hiccups, because it makes the patient move and you're trying to operate, and that doesn't work out too well. So we figured out a way to stop that. And then we also did some studies on fluids. So when I got to the nursery, I got to study respiratory physiology, neonatal physiology, and that all led to the development of CPAP. Next slide, please. So Dr. Hamilton allowed me to go to the work in the nursery, and that's led to the development of CPAP. And it seems like that was a major advance in neonatology because it increased survival significantly. And it was all due to a paper that came from South Africa. And this paper I read one day in the newborn, and then when it was published in the newborn intensive care unit, and what they were interested in is why do babies grunt when they have hyaline membrane disease? And you could hear those babies down the hall. They go, oh, 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 oh. And I mean, I could be 50 feet away and I could hear that baby grunting. And they want to know, why do they do that? And so they took a group of babies who were grunting and normal babies, and they studied their physiology. They put a balloon into their esophagus and measured the esophageal pressure. They measured their tidal volumes. They did really interesting, good studies. And they showed that if they put in an endotracheal tube, babies got worse. Their pressures went down, and they didn't do very well. So they put the tube back in, and they did well. They did better. Their gases improved. And so I looked at that and I said, well, why didn't they just put positive pressure on the end of that endotracheal tube? If they had done that, you would have grunted for the baby, their lungs would have expanded, and they would have been better. Next slide, please. And these are some other people, by the way, and I'll get back to that. These are some other people who were important in the development of this. Julius Comro, who was the first director of the CVRI, taught the importance of careful physiologic measurements. And they used to have their rounds on Saturday morning, and they were from 10 to 11. And so I would go to the anesthesia ground rounds from 8 to 9, and then I would go up there and I would listen to the rounds and what they had up there. And I learned an enormous amount of physiology by going to those grand rounds every week. And then there's Bill Tooley, who started in intensive care nursery and created a stimulating and supportive environment for everybody. And he questioned everything everybody did, and that taught me to do the same thing. Bill Hamilton was the chair of anesthesia, and he really supported my work in the nursery and pushed me to continue to do it. And John Clements provided the intellectual guidance and stressed the importance of critical care thinking. And Roger Phibbs and Joe Pitterman, who's sitting back there, were colleagues and close friends. And they were the ones who taught me newborn care. And I'm forever grateful that they did that. Next slide, please. And this is where things were when we started this. So assisted ventilation was not doing well throughout the world. And about the survival rate of mechanical ventilation was about 35% if you had hyaline membrane disease. It was awful. And that was whether you were in England or Canada or France or all the other places, South Africa, it just wasn't good. Next slide, please. And so we knew the background of this. And so atelectasis was the basic physiologic problem with these patients. And we knew that John Clements had demonstrated a powerful surfactant in the lungs, and that Avery and Dean had shown that it wasn't there. And they had, Chu, Clements, and Tooley, and many others had advanced the knowledge of this disease in their studies. And that study by Harrison that abolishing grunting decreased arterial oxygenation. And then Penelope Cave Smith, who was at Stanford at the time, she was working in the nursery trying to ventilate babies also. And she found that if she prolonged the inspiratory time, so made inspiratory time longer than expiratory time, the oxygenation improved in these babies. She didn't improve, they weren't able to improve the survival of the babies very much, but she showed that you can improve it by making their pressure in their lung better or longer. And then I at the time was using ventilators which were not very good. And I noticed that when I caused inadvertent positive index respiratory pressure, the oxygenation improved. And so that was another thing leading me to think that maybe positive index respiratory pressure might be useful. Next slide, please. And this is a slide which is really interesting. I don't have a pointer, so I'll have to stand up. Well, maybe I won't. But up in the upper side, on the left side, this is a normal baby breathing, and this is what they saw. And they saw when you pressure in the airway went from minus, or in the pleural went from 0 to -5, they got a tidal volume of about 7 cc's per kilo, or 7 cc's there. I'm sorry, for that 5 centimeters of pressure, they got approximately a 7 cc per kilo tidal volume. Well, that's what you're doing right now, sitting here in this room. You're changing your pleural pressure by about 5 centimeters of water, and you're taking in about 500 cc's of air. So you have about 7 cc's per kilo. So one number in pulmonary physiology that's common in both babies and adults. Well, now if you look over here, so that was the normal. Now you look over here and look at the top up there. The baby was going from 0 to about -15. Oh, thank you. This one? Oh, the middle. To -15 here. So they were taking 3 times as much pressure to generate a tidal volume that was a third of normal. They were doing an enormous amount of work. And we later showed in a few babies, Joe and I, that if you had babies who were not growing with mechanical ventilation, without mechanical ventilation, if you intubated them and ventilated them, they could grow better, and took away that work of breathing. We never published that. We probably should have, but it was like a lot of things that never got published from the nursery. But what you saw here with tidal volume was very different than this. They took a breath, they exhaled, quickly took in another breath. Another thing that's different in their breathing and yours is that we pause during exhalation. They don't. If the baby pauses during exhalation, they become more hypoxic. Because part of that reason for breathing 30 to 60 times a minute, I think I'm going too long. I see Mike looking at his watch.
Doing great. We have lots of time.
Either that or he has a date. So they don't pause. So if in the operating room, if you give them a drug like a narcotic and make them slow down their respiration, their gases frequently get worse. That doesn't happen in adults usually. Well, look at what happens right here. This baby takes a breath, holds his breath for a long period of time, exhales, quickly takes in a breath, holds it. And if you look at this in real time, you'd see that this time in exhalation is really short. And then he goes back to holding this for 3/4 of the respiratory time of the breath. And as I said, I looked at that and I said, well, all I had to do was put positive pressure at the end of that, and they would make this baby better. Next slide, please. And this is just showing what happens. So this is surfactant, this yellow stuff. And these were made by Bill Tooley. And when you take a breath, you spread this stuff out, and you exhale, it comes back and compresses. It lowers the surface tension, so your lung does not collapse during exhalation. And so you can breathe better. Next slide, please. And when you do, and if you don't have surfactant, you progressively decrease your lung, and pretty soon you have atelectasis, and then your PO2 goes down, and you don't do very well. Next slide, please. Next slide, please. So that night we had an opportunity to do that. We used this simple anesthetic circuit that's used throughout the world to ventilate patients and to ventilate babies. which had and so we put in an endotracheal tube. We connected it up to this system, which had a balloon on the end. And by squeezing the exhalation tube here a little bit, we could augment and increase the pressure here. And we could measure the oxygen here. We put this thing here so we can measure the pressure that was being generated in the system. And at John Clements' suggestion, we put this tube in here underwater to prevent the pressure from getting so high that we would get a pneumothorax. And that was John's came up to the bed with Thule, looked at it, and I said, yeah, we had a baby with a pneumothorax. And John said, well, just put it underwater. And when the pressure gets high, it'll go away. You won't have the problem anymore. And it got significantly better after that. That's how bright John was. I can tell you, every time I went to his office, I would say, John, I have a problem. And John would say, well, let's go back to first principles. And often he would develop an equation which would tell me what the problem was and how to solve it. That was the kind of mind he had. Nothing like I have. Change the next slide, please. And I also wondered whether I could do this without an endotracheal tube. Well, this is a trash bag from the nursery. And so I put hoses with oxygen going in on two sides. I put sound suppressors in here because with that oxygen going in there, you're going to be very loud. Put cotton around the baby's neck so that we weren't applying pressure immediately on the vessels in the neck, and raise the pressure in there. And we could measure the pressure in there. And you can see this baby, who I think is about 1,300 grams, breathing inside of this thing. This baby did really well. He survived and didn't have any problems. And so we then did some babies like this, and some babies require intubation. Next slide, please. And if you had to ventilate the babies, you could squeeze the bag. And any of the people who were my residents know that when they tell me they're bagging the patient, I get really upset, because bagging the patient, you bag garbage, you ventilate the lungs of patients. And I think lots of people in this room heard me tell them that, but I really was bagging the patient. Next slide, please. Well, that night, when I read that paper from South Africa, there was a baby who was 3,800 grams, who was born by elective cesarean section at 38 weeks gestation. And this was in March 1969, and the wife of a ophthalmologist at the Naval Hospital in the East Bay. The baby developed cyanosis, respiratory distress, shortly after birth. And he was sent to UCSF because rationally they thought, this is a big baby. He has cardiovascular disease. And so I went with Dr. Rudolph, the cath lab, and he cathed the baby and found that the baby had an absolute normal heart. So you have to remember that about 5% of term babies had, or 5% of the babies with high membrane disease were term babies. And so I don't know whether this baby had his cord clamped early or not, but he was a C-section and probably did have it clamped fairly early at that time. So I had the opportunity that night to apply 8 millimeters of mercury pressure to the lungs with that system that I showed you. And the PO2 rose to above 70 millimeters of mercury in less than 30 minutes, from 30 millimeters of mercury. And in a couple of hours, in an hour or so, it was above 230 millimeters of mercury. So we were able to come down on the oxygen very quickly. Next slide, please. Well, the first 20 infants had birth weights of 930 to 3,830 grams. And most babies with 930 grams with Hyla membrane disease did not survive. But we had some babies in this range who survived. These babies had severe Hyla membrane disease. Their PO2 was less than 50 in 170 to 100% oxygen, or they had apnea. And remember that these babies are doing an enormous amount of work trying to breathe. And they can't do that. They give up. And they would often die if you didn't treat them. So in many places around the world that couldn't treat them, they did die. And the highest CPAP we used was 6 to 12 in these 20 patients. And one of the things we were concerned about, and especially Dr. Kitterman sitting back there, was concerned about was that a lot of the pressure that we were applying to the lungs was being transmitted to the vessels in the lungs, and that we were interfering with pulmonary blood flow. By measuring esophageal pressure, we found that fortunately only 20% of the pressure applied was being transmitted to the pleura, and that so that we didn't have those problems. And that was probably because of the stiffness of those lungs to begin with. The duration of CPAP was 2 to 29 days. And the amazing thing was that 16 out of those 20 patients survived. That's an 80% survival when the survival rate on mechanical ventilation was about 35%. And the other important thing that we never followed up on and should have was that none of these babies developed chronic lung disease. None of them developed chronic lung disease. Many babies with hyaline membrane disease nowadays still develop chronic lung disease from the treatment that they get. So I went back and tried to find the data. It's been lost from the nursery, so I can't get the data, the follow-up data. Next slide, please. And this just shows that there was a marked improvement in survival. These 1,000-gram babies, there was a marked survival, and up until 1992, there was about a 20% mortality in these patients. And these are the babies, most all of whom died before. And you can see as the bigger babies got bigger, get better, that the survival rate from hyaline membrane disease is almost 100% now, if you're one of the larger babies. Next slide, please. And so the oxygenation increased, survival increased. And interestingly enough, we showed that there was a decrease in tidal volume and a decrease in minute ventilation when we applied positive mid-expiratory pressure. Now, if you look at that, just see that, you'd think the babies would be worse with that. But what you can't see under this picture of me is that their CO2 did not change. And their none of the blood pressure and things didn't change. So the fact that the CO2 didn't change and their ventilation went down suggests that there was an improvement in the ventilation of these babies during that period of time. That is, a mix of the ventilation, the ability of the lung to ventilate was better, but the minute ventilation that the baby needed to accomplish that was not there. Next slide, please. So CPAP is now applied usually by a mask or by a mask, by a nasal route. There's a group in Italy that has made a head box. This is one of them. It applies the pressure around the chest, and that works really well. And animal data has now confirmed that there's no chronic lung disease when you apply CPAP to animals that have hyaline membrane disease. When you do it through an endotracheal tube, you do it by other ways, you get chronic lung disease, but you don't do it in this way. Unfortunately, most of it is applied with these other methods. And CPAP is an important mode of therapy in the developing countries. And I think this is one of the things that this has allowed that it was an important advance, because they don't have the money to afford ventilators. And they don't have the training that allows them to do it in many, many places. And CPAP was inexpensive, and it was effective. So it was taken up by people around the world very quickly. Next slide, please. And so in summary, it is possible to do research while taking care of patients and teaching. And the way that you can do that is because you have good mentors like Clements and Tooley and Phibbs and Joe Kitterman, and you have colleagues to work with who will discuss problems with you and questions and question everything that you do. And that is very important. And you have chairs that support what you do, and like the ones that I mentioned. And Mike sitting over there, supporting people, doing research and trying to get things done. You have unsolved problems that interest you. That's important. Find a problem that's interesting and then figure out how to solve it. And you find the ability and time to investigate a question and develop its treatments. And if you do that, you can have a very successful career. So next slide, please. Thank you very much. I appreciate your coming.